in the WCLC 2024. In the they presented TROS2 trial. TROS2 trial, it was about this drug taletrectinib, and it had included ROS1 positive lung cancers, like both which had prior treatments and both who had treatment naive as well. And they found response rate in those who were treatment naive of almost 85% response rate in those patients, and those patients who had received prior ROS1 inhibitors, they had response rate of 62%. So, like quite a significant. You can say the response rate, in terms of response rate is concerned, this drug had in NSCLC patients who had ROS1
Yes.
mutation positive. This was the TROS2 trial. So going to the next question, this is another drug,
Yeah.
olomorasib. So olomorasib acts on KRAS G12C or VEGF or EGFR A110T or TROP2. The answer lies in the question itself. So times of, so olomorasib, it has got RAS in it. So this is a KRAS G12C inhibitor, and again, this abstract was presented in the WCLC 2024 in the LOXO RAS 20001 trial, which is a phase 1B study of olomorasib plus pembro plus chemo in first line NSCLC. Those patients who had KRAS G12C mutation, and PDL1 was 1 to 49%. And in this patient, they found response rate of 50%, which was quite significant. So olomorasib, it is a KRAS G12C inhibitor. And we know that these KRAS mutation patients, they are usually difficult to treat patients. Many times, like these patients, they don't do well. And so this can be a practice-changing trial, and many of the times, like we treat them with chemotherapy along with IO. And if you have in the first line a drug which is having such so good response, it is going to be practice changing in future. Okay, so coming to the next slide. So this is another drug, BAY 2927088. BAY 2927088. This is an anti-TROP2. This is a TKI against mutated HER2. This is a 4th generation ALK inhibitor, or this is a 4th generation anti-EGFR. Okay, times of. So this is a TKI against mutated HER2. Like those NSCLC patients who harbor a activating mutation in the HER2. So for these patients, this drug 2927088 acts on this mutated HER2, and it was tested in a SOHO-01 trial. SOHO-01 trial again was presented in the WCLC 2024, and it had got overall response rate of more than 70%. In the more than 70%, and so it is being tested in first line as well in the phase 3 trial at present, along with in comparison to standard of care, which is chemo plus IO. So BAY 2927088, it is a TKI against mutated HER2. So going to the next question, Jongertinib. It is an anti-TROP2. It is a TKI against mutated HER2. It is a 4th generation ALK inhibitor or a 4th generation anti-EGFR. Jongertinib. So time's up. So again, this is again a drug. This is again a tyrosine kinase inhibitor which acts on mutated HER2. So this was tested in another trial named Bimian Lung 01 trial. And again, it was presented in this year's WCLC, and it had shown to be having response rate of more than 70%, which is quite significant. So Jonjotinib, it is an anti-TKI against mutated HER2. So going to the next question. This is a very interesting drug. Ivonescimab. Ivonescimab is anti-PD-1 and VEGF inhibitor, anti-PD-L1 and VEGF inhibitor, BRAF and VEGF inhibitor, IDH1 and VEGF inhibitor. Ivonescimab.
This is going to change the practice.
Please, I would request again the technical team, all the people who have joined, please mute yourself, keep your video switched, mute yourself, keep your video switched off, otherwise we are logging out of this webinar.
Ivonescimab. This is a anti-PD-1 and VEGF inhibitor, and this is a very interesting trial known as Harmony trial, Harmony 2 trial, in which Ivonescimab was tested against the pembrolizumab, and they had taken all the PD-L1 positive patients, like 1% to 49%, the patients also they have included, and like single agent Ivonescimab was tested against pembrolizumab, and it had found significant hazard ratio of 0.51 in terms of median PFS in first line. And so at present it is being tested in Harmony 3 trial with chemotherapy. That is Ivonescimab with chemotherapy versus pembro with chemotherapy. So Ivonescimab is the anti-PD-1 and VEGF inhibitor. Going to the next. So this is another drug, datopotamab, or otherwise known as datopotamab deruxtecan. So is it a ADC against mutated, ADC against c-Met, antibody drug conjugate against TROP2, or ADC against BRAF? The ADC against TROP2. So this was tested in Tropion Long 01 trial, and this trial was in second line. So patient would have received first line treatment, and it was tested against docetaxel, and it was found to have significant PFS benefit only in non-squamous population. The overall survival benefit was not there. It is like we know that in second line, in terms of overall survival, beating docetaxel is very difficult. So datopotamab deruxtecan was tested against docetaxel. So overall survival was benefit was not there against docetaxel, but in particular population, non-squamous population, if we see, there is almost 2 months of PFS benefit was there in against docetaxel for datopotamab deruxtecan. Is there antibody drug conjugate which acts against TROP2?
Lola, if for the sake of time, can we restrict it to this? We have 6 questions, right? So I think there are other presenters here.
Three more questions.
Three more questions. Okay, please.
So going to the next question. This is another drug, that is telisotuzumab vedotin. Telisotuzumab vedotin, whether it is a antibody drug conjugate against mutated HER2, or ADC against c-Met, ADC against TROP2, ADC against BRAF. This is an ADC against c-Met, and again this was and this drug was tested in Luminosity study. Luminosity study was presented this year's ESMO, and again in those patients with say c-MET overexpression. In non-squamous non-small cell lung cancer, overall response rate was almost 28% was seen, and those who had having like higher c-MET overexpression, in those almost 35% of overall response rate was seen. So coming to the next question. Next question is NVL 655. NVL 655. NVL 655. This is a ALK inhibitor. This is an fourth generation ALK inhibitors, but it spares the TRK. We know that most of the ALK inhibitors like lorlatinib that we know is so along with inhibiting the ALK, it also inhibits the TRK because of the structural similarity, and most of the CNS toxicity that we see with lorlatinib is because of the inhibition of the TRK. So this fourth generation NVL 655, it inhibits the ALK but spares the TRK, so it spares the CNS toxicity that we see with the lorlatinib, and has got good CNS penetration as well, and overall response rate of almost 71%, and it also acts like response rate is still good in those persons who had been exposed to lorlatinib before. So in NVL 655, this might change the practice in future. This is having a lot of promise. This has shown a lot of promise in this ALCOV-1 trial, which was presented in this year's ESMO. So going to the next question, which is false about the mechanism of acquired resistance in Mariposa trial. So the fourth option is wrong. So Mariposa trial, we know that it is the amivantamab with lazertinib was tested against osimertinib in EGFR mutation positive lung cancer NSCLC patients in first line, and what they found, and median PFS was almost 25 months, which was quite significant, and almost 6 months, 7 months better than the osimertinib, what we see with osimertinib. And what they found in the combination arm, that is the arm that had received amivantamab with lazertinib, MET amplification was 3-fold lower in combination arm, and secondary EGFR mutation was 8-fold lower in the combination arm, and there was no increase in other mutations as well, and there is lower rates of TP53 or RB1 loss in the combination arm. So higher rates of TP53 RB1 loss in the combination arm is wrong option in this question. So last question. This is another very interesting trial, Pharos trial. Pharos trial, which was which included all the BRAF V600 mutated NSCLC patient. So which drug was tested? So it is encorafenib plus binimetinib. This was tested in Pharos trial, and they had found almost 70% of response rate and median PFS of almost 12 months in patients with BRAF V600 mutation positive mutated NSCLC. Thank you so much.
Thank you, Lolatendu, for that beautiful assortment of questions. And I would request the technical team, we can have the winners declared at the end. So you can go through the chat box and find out who were the winners, that is the fastest finger first, and then you can tell us in the end, right? So we will now go to the next session, and that is by a panel discussion by Dr. Prashant Parida. He's I would request everyone to please keep quiet. He's an associate professor in the Department of Medical Oncology at HPGIC, the Premier Cancer Hospital at Cuttack. And I would request Dr. Prashant Parida to take over, introduce the panelists, and make his presentation. Thank you.
Thank you, Dr. Saurabh. And I'll thank the expert team for organizing such a wonderful webinar. I hope all my panelists are present. Now my slides are visible.
Yes, sir, visible.
Yes. So my panelist, Dr. Lipsita, Dr. Sachin, both you are present, Dr. Sachin and Dr. Lipsita.
Yes, sir.
Dr.
Yes, sir.
Tanushree and Dr. Stiti.
Yes, sir.
Yes, sir. Good afternoon,
And
sir.
Dr. Niharika, madam.
Good evening, sir. Sorry.
Yes, I am present. Good
So
evening.
directly.
A very good evening to all of you.
Good evening. Good evening. So directly we'll start the case-based discussion about the early stage management of early stage lung cancer. So this is a 67-year male, non-smoker, presented with mild cough, and his chest X-ray shows a small lesion in left upper lobe, and the CT scan chest has been done outside, which shows there is a small lesion in left apical lobe. This is the CT scan picture you can see. So how you will proceed? After the sorry, you are there.
Sorin has not joined. So basically, we don't have a surgeon, we don't have a radiologist and pulmonologist. We have medical oncologist ready.
Okay. Saurabh, if possible, you can join. Okay.
Okay.
Okay. Thank you. So, Dr. Sachin, so someone with a small left long lesion presented to you, and how you will work off? What are the imaging test and what are the lab test you will do, and how will you proceed in this case?
I will first, in a case of suspected lung cancer, I will first try to stage it clinically, assigning T and N stage. If it is more than stage 2, then for staging,
No. We have not gone to stage yet.
Yes.
We are still not done, not confirmed with whether it is a lung malignancy or not. So, what are the imaging tests and other laboratory tests you are going to advise in this patient?
For imaging, a simple high resolution CT thorax will be sufficient if we are suspecting a lung cancer. And depending on the location of the tumor, we can either go for a CT guided biopsy or we can plan a bronchoscopy for tissue sampling. And as far as lab tests are concerned, we will order CBC, KFT, and LFT.
So still, because looks like a early stage, if malignancy possibility of because CT scan shows no mediastinal nodes or any other nodes there in the CT thorax. So still you should sample it or you will go directly for surgery. Tissue sampling.
Tissue sampling is required before proceeding directly to surgery.
Okay. Anyone of my panel members want to differ from Dr. Sachin? Okay. So, Dr. Lipsita, what are the imagings you want to any further imaging, because we have done already CT thorax only, and assuming possibility of malignancy, any other imagings you are or any other test you will advise in this case?
Since we are seeing a lung lesion, first we'll do a biopsy to confirm the diagnosis. We'll know the histopathology, and after that, since the lesion looks big, I think we should, after confirmation with biopsy, we can go ahead with PET CT to look for any other site or
The
means surgery will be at risk, and it is a borderline tumor like stage 2B onwards. So we need to be very careful about assessing. So there are many factors where because of that many persons they and also in our setup, in our scenario, we get a long waiting period. So during that period also patient may develop to an operable to inoperable. So that's why the
Yes.
percentage is very less.
Yes. So a lot of factors should be considered before considering resectability, starting from the PORC1 status, comorbidity, any medical conditions, even pulmonary disease, whether that patient can sustain the resected lung volume. So that is also very important. And a surgeon or a thoracic surgeon who is going to do surgery, whether he is confident enough to have negative margin, including complete removal of the primary as well as negative margin at the lymph node basins also. So these are the factors should be considered for considering resectability in early stage lung cancer. Dr. Sthiti, especially someone presenting with N2 disease. So I will evaluate especially in a operability or resectability point of view, because most of the institutions, they considered almost half of the institutions they consider surgery, half of them consider induction chemotherapy or chemoradiation. But still it is a N2 disease, it is a controversial topic. So what are the options, or in which subgroup of patient you can consider surgery in N2 disease?
I think surgery is definitely an option, and it's a gold standard of treatment for early stage lung cancer. And mostly for even though for mediastinal lymph node positive disease, we can opt for surgery. But sometimes if there are large lymph nodes, we usually go for induction chemotherapy or preoperative chemoradiation in these cases, where we can downstage the disease and then go for surgery. But usually up to N1 disease, surgery can be considered. And if there is any high risk N2 disease, like if after surgery there is upstaging of the disease to N2, then we can go for adjuvant chemoradiation or adjuvant chemotherapy.
Yes. So historically, most of the N2 disease, we have treated them with chemoradiation, and the outcome fiber survival only 10 to 20% in stage 3 or N2 disease. But there are a few subset of N2 disease, especially single involved lymph node stations, or should not be bulky disease, microscopic N2, or successful downstaging, as Dr. Sthiti has already told, to the mediastinum followed by neoadjuvant chemotherapy. And only T3, T4 disease due to size, not due to invasion or extension, and the patient is having good performance status, younger age. And these are the subgroup. Even in N2 disease, you can consider surgery in this subgroup of patient. So in our case, patient has undergone surgery, and it is histopathologically invasive adenocarcinoma, and margins negative T2N1. So this is the histopathological reporting. Dr. Niharika, you are there? So in adjuvant setting, especially early stage lung cancer, because we know that molecular tests, especially a broad molecular panel by NGS, which is preferred in advanced stage non-small cell lung carcinoma. So do you recommend routinely in early stage lung cancer for any biomarker, any specific biomarker?
Yes, in early stage, if we are thinking of non-resectable, or at least we should have 3 markers minimum. We are sending for markers, and at least the 3 markers, ALK, EGFR, and nowadays almost all clinician wants PDL1 also. So we are sending for at least these 3 markers, and what if it is non-resectable or non-resectable? Ultimately, 10 to 12 genes are required. All the panels are done. So preferably when we get the tissue in small biopsy also, pre-surgery tissue, we go for the entire lung panel biomarkers, including the ALK, EGFR, BRAF, ROS, MET. Nowadays, MET, they are the new mutation, or MET also they are wanting.
Yes. So rightly said, though in adjuvant setting, especially at least 3 markers. So EGFR, ALK, and PDL1. So we have options of using EGFR TKI like osimertinib and
evaluate the kidney function because some anticoagulants, like in this case, dabigatran, is not recommended in patients with a lower.
So, Dr. Saurabh,
Yes.
there is some background noise. Someone is presenting.
Yes.
Okay.
I think now
So,
it's better.
at least we should have at least these 3 biomarkers like EGFR. We have EGFR TKI like osimertinib based upon ADAURA trial, and ALK. Recently, ALK TKI has been approved. That is based upon alectinib, based upon the ELINA trial. Recently, it has been approved by FDA. And PDL1, we know that atezolizumab especially and pembrolizumab, more than 1% PDL1, we have options of using adjuvant IO also. So these 3 are definitely we should do in early stage lung cancer. But as Niyarki madam has already told, because the tissue sample sometimes we may exhaust by doing a sequential test or individual test. So better to have a panel. So we can, most of us are sending the panel. This is what madam has told. So you can do that, but at least we should do these 3 markers. Madam, whether the pre-surgery tissue or post-surgery tissue, both are equivalent, or you will advise in post-surgery tissue, these biomarkers?
It depends on whether the patient will take chemotherapy or not. We can go for post-surgery tissue also, if it is a resectable tumor.
Yes, but if someone has been exposed to some neoadjuvant chemotherapy or immunotherapy, whether the tissue sample, whether by doing biomarker test, so there will be any change, or we can advise even someone has exposed to neoadjuvant therapy.
We are doing, even post chemo, we are doing, because sometimes the tumor, we don't re-biopsy the tissue, we send liquid biopsy also. So I don't think the mutational changes will be there. So we can go for post-surgical tissue if post chemo also. Already exposed to chemo, we can go for the molecular studies. I don't think the biomarkers will change.
Okay, madam. So this patient has undergone surgery, T2N1 pathologically. Now comes to the adjuvant radiotherapy. And Dr. Sthiti, post-op radiotherapy in resectable or early stage lung cancer who has undergone surgery, adjuvant post-op RT. So where and when you should recommend, in which subgroup of patients?
Usually, we are not recommending post-operative RT in early stage diseases except for margin positive cases. So if there is a margin positive case, R0, R1, R2 resection, then we usually go for post-operative radiotherapy. And suppose if there is upstaging to N2 disease, and after surgery we are seeing that there is upstaging of N2 disease. So in high risk N2 disease, like if there is an extracapsular extension, or there multinodal lymph node involvement, or there is inadequate lymph node sampling, or there is any contraindication for chemotherapy, patient is not able to undergo adjuvant chemotherapy, we may offer post-operative radiation therapy to these cases.
Okay.
After resection.
Dr. Tanushree, you want to differ, or you will recommend in similar situation?
Yeah, I'm completely agree with madam that only margin positive is the definite indication for post-operative radiotherapy in case of post-op early stage lung cancer. But as ma'am has already stated that in these high-risk selected patient, we can go for post-operative radiotherapy.
Yes. So R1, R2 resection, or sometimes multinodal post-op, you can get N2 or N3 disease, then you can consider adding RT to concurrent chemoradiation or chemotherapy. Dr. Sthiti, you have done a lot of SBRT. Your experience of SBRT in early stage non-small cell lung carcinoma, and which patient you should recommend SBRT?
Yes, SBRT or SABR, like we are telling it now, stereotactic ablative radiotherapy, is a promising option for early stage lymph node negative diseases where there is very high risk for surgery. There is a medical contraindications owing to old, like more age group, like more than 75 years of age, or there is any cardiac dysfunction or poor lung function, or patient is denying surgery, we can definitely offer SBRT to these patients. Though we also agree that the results are like overall survival not equivalent to lobectomy, but in these conditions we can offer SBRT, and it has been seen in number of studies that they offer good overall survival and cancer specific survival for these patients. So SBRT or SABR is an option for early stage disease, and also it is a very good option for oligoprogressive diseases where already the primary has been radiated and we have seen limited metastasis like 3 to 5 metastasis in other areas like spine or bone or adrenals. We can offer SBRT in these patients because hypofractionation we have seen that it gives a good local control as comparison to conventional radiotherapy. So this is also an option,
Excellent.
and for bone metastasis. Like if you go see there are painful bone metastasis, SBRT has given good results in comparison to conventional RT.
Yes. So if someone is medically not fit or comorbidity, solitary lung nodule, SBRT have a role. Even oligoprogression, as you have rightly said, SBRT also has a role.
So is there any size cutoff for this early where SBRT is to be given?
Yeah, usually we go for tumors which are less than or equal to 5 centimeter, but we have also radiated sizes more than 5 centimeter, but usually we go for less than to equal to 5 centimeter lesions.
Okay. So these are the indications what we have already discussed. Now coming to neoadjuvant therapy. Dr. Sachin, role of neoadjuvant therapy in early stage small cell lung carcinoma, because previously, historically, we have used only platinum doublets. Nowadays, we have IO in combination with platinum doublets. So, role of neoadjuvant therapy in early stage lung cancer, Dr. Sachin.
As far as neoadjuvant therapy is concerned, previously also for superior surface tumors, we were using neoadjuvant chemoradiation, and now so that the immuno-oncologic drugs are available, and with use of these immuno-oncologic drugs, there is a substantial improvement in disease parameters. Neoadjuvant therapy is more and more becoming favorite of medical oncologists, recommending to resectable cancers.
So, in your experience, which
as my experience goes, I have not used any till now. But
I think Dr. Prashant Parida has been logged out. Anyway, so we can take his discussions, he can join. So basically, Sachin, whenever we go for neoadjuvant therapy versus chemotherapy, I mean neoadjuvant immunotherapy versus chemotherapy. So what is usually the outcome with neoadjuvant immunotherapy compared to chemotherapy? What do we get?
we usually, in terms of pathological response and event-free survival, these are the main primary endpoints we are seeing. Some of the trials that recently came up, like AGN, they were the pathological complete response was higher in the neoadjuvant IO plus chemotherapy group rather than the placebo group.
Basically, whereas neoadjuvant chemotherapy would bring a response rate of hardly 1 to 2% CR complete response or major pathologic response, the immunotherapy combination can bring around 1 in 3 patients, 30%, 40% major pathologic response, right? So, Dr. Niharika, major pathologic response, how it is now? This was something new for us. I mean, in lung cancer, we never heard of about neoadjuvant therapy. Now there is a lot of neoadjuvant therapy planned. So, how is major pathological response and a pathology complete response defined actually? Niharika madam, are you there? Lipsita, you can take it up then. So basically, major pathologic response and pathology complete response. Yeah, Lipsita, are you there? Yeah,
Yes,
yeah.
sir. Sir, major pathological response is basically when less than 10% of viable tumor is present, then it is called major pathological response.
Okay. And when there is no viable tumor, it is a pathologic complete response.
Yes.
Right. So basically now we have data for incorporation of immunotherapy, nivolumab, ipilimumab, as few as 2 cycles are good enough. Now would you incorporate, now there is a lot of use of these targeted therapies, EGFR TKIs, even in adjuvant setting after concurrent chemoradiotherapy. So suppose a patient is there, let us say stage 3, and we have done a biopsy, and in that we have found that the patient has got an EGFR sensitizing mutation. Do you think anti-EGFR therapy as a neoadjuvant therapy has been explored, or is there anything to suggest that they would do good?
EGFR in neoadjuvant has not been explored much. So it is in the adjuvant setting and metastatic setting that it has a major role.
Right.
So we are exploring more of immunotherapies in this setting. We are using nivolumab, pembrolizumab, durvalumab, all have been tested and found to have good response.
Right. So there was one study in which they gave neoadjuvant immunotherapy, neoadjuvant osimertinib in patients with EGFR sensitizing mutation, and they found that they could not reach the pre-specified cutoff for major pathologic response. It was low. It was only 14%. So therefore, they did not go ahead with the phase 3 studies. So this shows how complex lung cancer is, whereas osimertinib has done wonders in a lot of settings, but definitely neoadjuvant setting is something where we do not have data with EGFR TKIs, even if we have a sensitizing mutation. And therefore, in the neoadjuvant setting, we usually go ahead with immunotherapy and mostly nivolumab, ipilimumab, or nivo plus chemotherapy or pembrolizumab. Some of them have used also perioperative approach. That is, they have gone for pre-operative, and then after surgery, they have gone for post-operative. And there is some data to say that PD-L1 expression brings about some response, and also that those who have gained a complete response to pre-operative therapy may not benefit much from post-operative therapy, post-operative immunotherapy. So those all things are there which can be discussed with the patient when we are planning. But good thing is that at least we discuss in our patients. 1 minute, Dr. Parida is calling me. Yeah. So basically, Dr. Prashant is back. Dr. Prashant, you are there? Having some issues. Prashant bhai, apna option. I mean, we can see you. So there is some technical problem there. So basically, neoadjuvant setting we discussed. Now we will go to the next presentation from Dr. Sri Gopal. So I would like to thank all the audience. Basically, the focus today here was staging of lung cancer, where we discussed that we have to go for PET-CT scan, MRI brain imaging, because even in early stage, because patients otherwise will be missed out with occult metastasis. We also discussed that when we are planning a surgery, we have to go for the mediastinal staging, and that can be either through an EBUS or bronchoscopy or through the mediastinoscopy. And after that, we have to discuss in a multidisciplinary tumor board about the intent of treatment. We have to accordingly incorporate neoadjuvant therapy. We have to do some biomarkers like EGFR, ALK, and PDL1, and then subsequently we can go for adjuvant therapy based on the surgery. So I would like to thank Dr. Prashant Parida, all the panelists for this excellent discussion. Now we will go to the next talk, and this talk is by Dr. Sri Gopal, and he is a consultant medical oncologist at HCG Panda Cancer Center. And Dr. Sri Gopal will be taking us through the consolidation therapy in non-small cell and small cell lung cancer after chemoradiotherapy. So over to Dr. Sri Gopal.
Yeah. Thank you, sir. Good evening, everyone. So hope my slide is visible and I am audible.
Yes, please go ahead. You can make it full screen.
Yeah. Yeah. So first of all, I would like to thank Saurabh sir and team IAIO and Astra for giving this opportunity. So I will be talking on consolidation strategy after chemoradiation in locally advanced lung cancer, be it non-small cell or small cell lung cancer. So just to brief that lung cancer is the leading cause of cancer-related death worldwide, as we all know. And out of all lung cancer, 15% we see small cell lung cancer and 85% major bulk is non-small cell lung cancer. Out of all small cell lung cancer, we see only about 25% are localized disease like the limited stage small cell lung cancer. Other 75% is extensive stage small cell lung cancer. So small cell lung cancer is a disease of elderly people and more common in smokers. And it is very highly aggressive disease. We see about 50% of patients develops brain metastasis during their disease progression. And if we talk about the staging, so we follow staging for non-small cell lung cancer, we all know, and PLSG staging for small cell lung cancer. So limited stage and extensive stage disease in small cell lung cancer. Limited stage is nothing but when we can encompass the disease in a single radiation portal. So particularly the disease is localized to one hemithorax and can be incorporated in a single radiation field. Whereas extensive stage disease is when the disease cannot be confined to a single radiation portal. So disease will be involving either the contralateral hilum, hilar nodes, or a contralateral supraclavicular nodes, or contralateral lung mates, or beyond the single hemithorax. So, the treatment, then limited small cell lung cancer, clinical T2, T1.
Sir, excuse me, sir. I'm really sorry.
Yeah.
Sir, please give us time to mute everyone. I'm sorry, sir.
Please mute. Yeah.
So when we talk about treatment of small cell lung cancer, particularly limited stage small cell lung cancer, if it's operable, so particularly clinical T1, T2, N0, upfront surgery, and followed by adjuvant chemotherapy. When we talk about inoperable limited stage small cell lung cancer, then treatment is chemotherapy, followed by prophylactic cranial irradiation in case of responders. So in case of extensive stage small cell lung cancer, the platinum-based chemotherapy and with radiation, followed by prophylactic cranial irradiation. So even after all treatment, this small cell lung cancer, they have a high chance of relapse because of the aggressiveness of the disease. So we can see here the advancement in treatment of small cell lung cancer in the limited stage. So starting from 1985, started with platinum-based doublets. Then you can see all throughout, then developed the thoracic radiation therapy. Then subsequently sequential and concurrent chemoradiation. There are studies to show that concurrent chemoradiation has shown a significantly improved overall survival compared to sequential chemoradiation, even in small cell lung cancer. So there is an era of about 3 decades when we didn't have any novel systemic therapy to have a better systemic control of this disease. Because you can see here that even in limited stage small cell lung cancer, 60% can fail at the local regional site and 20% can fail at the CNS site. So having this high aggressiveness of the disease, so to avoid this systemic failure, so the need of systemic therapy, some sort of novel systemic therapy is the high unmet need to improve the survival in this limited stage small cell lung cancer. Then comes this Adriatic trial, which is a phase 3 randomized controlled trial, is a multi-center international study that studied the stage 1 to stage 3 limited stage small cell lung cancer, particularly those who are inoperable, WHO performance 0 or 1, not progressed on previous chemoradiation, and it permitted the prophylactic cranial irradiation before randomization. So, stage 1 to 3 limited stage small cell lung cancer after completing chemoradiation. So they were randomized into the experimental durvalumab 1500 mg every 4 weekly versus placebo arm. So it was continued till disease progression or intolerable toxicity or maximum up to 2 years. The primary endpoint was dual co-primary endpoints. First was the overall survival, second was progression-free survival. You can see the baseline characteristic. Patient characteristics was equivalently matched between these two arms in terms of age, sex, race, performance status, smoking status, stage of the disease. So most of the responders to chemoradiation were like partial responders, and prior prophylactic cranial irradiation was allowed in this study. So about 50% of patients received prophylactic cranial irradiation before going for randomization. So we can see the primary endpoint of overall survival here, that median OS in the durvalumab arm was 55 months compared to 33 months in the placebo arm. The hazard ratio for OS was 0.73, p-value was significant. So we can see the Kaplan-Meier curve well separated starting from the 6 month, the tail end still well separated. So definitely there is a clear-cut OS benefit in the durvalumab arm. And if you look at this forest plot, there is a OS benefit irrespective of all subgroups. Here we can see the hazard ratio 0.7 to 0.5. So definitely there is a OS benefit in the durvalumab arm, irrespective of subgroups. Then if we see at the progression-free survival, the second co-primary endpoint, the median PFS was 16 months in the durvalumab arm compared to 9 months in the placebo arm. Hazard ratio again 0.76, p-value significant. We can see here again Kaplan-Meier curve very well separated starting up to the tail end. So it is quite well separated, and the p-value significant. Hazard ratio 0.76. Median PFS with durvalumab was 16 months compared to placebo 9 months. And again PFS, we can see the subgroup analysis. There is a trend towards PFS benefit, although all subgroups are not adequately powered, but still we can see across all subgroups there is a PFS benefit in the durvalumab arm. Then if we look at this safety profile, so when you talk about toxicity, we don't always talk about grade 1, grade 2 toxicity, because for clinicians, for oncologists, the major concern is grade 3 hair toxicity. Grade 1 and 2 toxicity is quite easily managed by all of us. So grade 3 for toxicity was seen in about 24% in the durvalumab and 24% in the placebo arm. So comparable between two arms. If you talk about immune-related toxicity, grade 3 hair immune-related toxicity was 5% in the durvalumab arm, and placebo it was 1.5%. So 5% versus 1.5%. Again, it's not a very big difference. So definitely it's a well-tolerable drug. So most frequent toxicity observed was radiation pneumonitis, which was 22% in the durva arm and 23% in the placebo arm. So it was most often due to the radiation, not due to the consolidation treatment. So other than that, anorexia, hypothyroidism, hyperthyroidism, these all sins, but everything was about grade 1 to toxicity. Grade 3 toxicity was everything was almost to the tune of less than 5%. So grade 3 hair toxicity, again pneumonitis, which was common, it was 3% in the durvalumab arm, placebo arm again was 2.66%. So there is not much difference. So treatment side effects leading to discontinuation was 8% in the durva arm compared to 3% in the placebo arm. So concluding this study, that durvalumab as a consolidation treatment after chemoradiation has shown statistically significant and clinically meaningful improvement in overall survival and progression-free survival compared to placebo in limited stage small cell lung cancer. So it is a safe drug and well-tolerated drug, can be continued up to 2 years. This is the ASCO guideline update for small cell lung cancer. It has recommended this consolidation durvalumab after completion of chemoradiation in a limited stage small cell lung cancer who has responded to chemoradiation. Now we'll see about non-small cell lung cancer. So we know that 75% of non-small cell lung cancer are diagnosed in advanced stage, which are inoperable. So this is what's on here. 25% of non-small cell lung cancer are operable, and 75% of non-small cell lung cancer, they are inoperable. So for this unresectable non-small cell lung cancer, we have treatment modalities like chemoradiation, be it a concurrent or sequential, then followed by consolidation strategy, which has come up recently. So these are all data for concurrent chemoradiation and for sequential chemoradiation. These are the different regimens. So overall meta-analysis of this concurrent versus sequential chemoradiation has shown that concurrent chemoradiation is giving a significantly improved overall survival benefit and PFS benefit, whereas at the cost of increased rate of grade 3 higher esophagitis. Now, if you talk about the consolidation strategy, then all this trial, they have failed to show that whether you consolidate with gefitinib or erlotinib or cetuximab, there is no OS benefit. Then came this specific trial. The specific trial is a phase 3 randomized control trial in unresectable stage 3 non-small cell lung cancer. They have randomized these subgroups into 2:1 into the durvalumab, which is infused 10 mg per kg every 2 weekly up to 1 year, compared to placebo. Then the primary endpoint was overall survival and progression-free survival. We can see here the Kaplan-Meier curve. The median OS in the durvalumab arm was 47 months compared to 29 months with placebo. The hazard ratio for OS was 0.72, and the p-value was significant. Now, if you look at the updated PFS, the median PFS in the durvalumab arm was 16 months compared to 5 months in the placebo. The hazard ratio for PFS was 0.55 and the p-value was significant. You can see the Kaplan-Meier curve. The curve started separating before 3 months itself, and the curve is, the separation is uniformly maintained till the tail end. So PFS for hazard ratio for PFS was 0.55, p-value significant, clearly separated this PFS Kaplan-Meier curve, but definitely there is a meaningful PFS benefit with durvalumab maintenance. This is the subgroup analysis. Here we can see the highlighted part that the EGFR mutation negative patients derive the maximum benefit with maintenance durvalumab compared to the EGFR positive tumors. So this is the first and only approved immunotherapy drug to demonstrate OS and PFS benefit in the consolidation strategy, in particular in stage 3 non-small cell lung cancer. Now, if you look into the stage 3 EGFR mutant non-small cell lung cancer, as we saw from the previous data, the durvalumab is giving a the significant benefit, particularly in the EGFR mutation negative tumors. Then what about EGFR mutation positive stage 3 non-small cell lung cancer? Now comes this, this LAURA trial. LAURA is a phase 3 randomized controlled trial. So they have incorporated stage 3 unresectable EGFR mutant non-small cell lung cancer who has not progressed during the definitive chemoradiation, and those patients having the mutation exon 19 deletion or L858R mutation. So within 42 days, 6 weeks of completion of chemoradiation, they randomized 2:1 into osimertinib 80 mg OD versus placebo. And the osimertinib was continued till the disease progression or intolerable toxicity. The primary endpoint was PFS, assessed by blinded independent central review team, and the secondary endpoint was OS, CNS PFS, and safety. Here is the console diagram. And the baseline patient characteristic was equivalently distributed between the experimental and the control arm. And majority of the patients had a partial response to the previous chemoradiation. Here we can see the primary endpoint, the PFS by the central review team. The median PFS was 39 months with the osimertinib consolidation arm compared to 5 months in the placebo arm. Here you can see the interesting thing is the hazard ratio. In oncology, getting a PFS hazard ratio of 0.16, which is very tremendous, like we don't see usually in our practice or in any trial. So PFS hazard ratio of 0.16 with p-value very, very significant. We can see the Kaplan-Meier, so very, very widely separated curve. The Kaplan-Meier curves the favoring the consolidation of osimertinib arm. The tail end, still we can see there is a very well big separation between the tail end. So hazard ratio 0.16. So definitely there is a PFS benefit with osimertinib maintenance. Here, this is the investigator assessed PFS. Again, the hazard ratio is 0.19. So there is a uniform PFS benefit with osimertinib consolidation post chemoradiation. And this is the forest plot showing that the osimertinib arm is giving definite PFS benefit across all the subgroups. If you look at the tumor response, the objective response rate was 57% in the osimertinib compared to 33% in the placebo. The DCR, disease control rate, was 90% with the osimertinib and 80% with placebo. The median duration response was higher in the osimertinib, 36 months compared to 6 months in the placebo arm. Now about the new lesion, the disease progression, the CNS progression rate was about 40% in the placebo arm, which is only 5% in the experimental the osimertinib arm. So definitely the maintaining the osimertinib upfront after chemoradiation, we are going to give a better CNS mets-free survival. Now, if you look into the overall survival, so there is no significant OS benefit so far. The reason is, major reason is 80% of the experiment, the control arm patients, 80% of patients who received placebo, they crossed over to the osimertinib after progression. So definitely 80% is not less. So there was no OS benefit, hazard ratio 0.81. So if we had not allowed the crossover, which is not a very legally correct, so definitely we are missing the OS benefit because of the crossover. The 80% of patients in the control arm crossed over to the osimertinib treatment after progression. So no OS benefit because of that. So if you look into the safety summary, this osimertinib is well tolerated. The grade 3 higher toxicity was about 13% compared to 3% in the placebo arm. And we don't usually talk about the grade 1 to toxicity, which we often see in our practice, well managed. So grade 3 higher toxicity, 13% in the osimertinib versus 3% in the placebo arm. Now, common toxicity encountered in this study was radiation pneumonitis, diarrhea. Definitely, radiation pneumonitis was due to the chemoradiation, and other toxicities was diarrhea, rash, and other like anorexia, other skin toxicity. So almost similar between two arms. So concluding LAURA study, so osimertinib is a consolidation treatment in EGFR mutant stage 3 non-small cell lung cancer after chemoradiation, so they definitely and significant clinical and statistical benefit of median PFS about 39 months with osimertinib compared to 5 months with the placebo, hazard ratio 0.16. This is the NCCN updated guideline 2024 showing that osimertinib 80 mg should be continued till disease progression after chemoradiation in EGFR exon 19 deletion or L858R mutation stage 3 non-small cell lung cancer. This is the ASCO guideline 2024. Again, the same recommendation. So to summarize, if I have a small cell lung cancer, so limited stage, not operable, after chemoradiation who responded without any progression, I will go for maintenance durvalumab. If no financial constant, in case of stage 3 non-small cell lung cancer, if it's a EGFR mutant, I will go for osimertinib maintenance. If it's a EGFR mutant negative, then no financial constant, then durvalumab maintenance up to 2 years. So thank you everyone for patientful hearing, and thanks again the organizers. I will hand over to the organizers for the next session.
Sir, please unmute yourself. Now you can do, sir.
Yeah. So thank you there. So there is a lot of technical glitches. Thank you, Sri Gopal, for that lovely talk. I would just like to say that we are really sorry. There just was a technical glitch. Both the accounts, Zoom accounts, have been corrupted for last some time, and therefore we immediately had to come with a new account and we had to share with it. That is why you are seeing these problems. So please bear with us. I would request now Dr. Prashant Parida to please present his talk on the
Sir, Dr. Saurabh, my
Yes.
slides are visible now?
Yes, you can please present your slides.
Okay. So now it is visible?
Absolutely, sir.
Okay. So we sorry for the technical interruption. Now we start again. And Dr. Sachin, we are discussing about neoadjuvant therapy, and what are the drugs? Because the IO data recently came. Before that, we all were using a doublet. So what was your preferred platinum doublet you have used in neoadjuvant setting? Dr. Sachin, you are there? Dr. Lipsita?
I think both of them are not there. Prashant, I will take this question if it is okay. Yeah, Lipsita is there. Yeah. Lipsita?
Yeah,
Yeah,
I'm
please.
not able to get the video, but I can. Yes, sir. So neoadjuvant, if it is adeno, we go with PEM cis or PEM carbo, and if it is squamous, then Pacli carbo or gem Pacli
Yes.
cis or gem carbo
Yes.
cis is preferable.
So platinum pemetrexate nowadays
Yes.
in adenocarcinoma and taxane plus platinum, cisplatin or carboplatin, or with gemcitabine can be used in non-squamous. So these are the IO trials, IO drugs like Aegean, Checkmate 816, Keynote 671, and Checkmate 7070. So these are the positive trials in neoadjuvant setting, and few positive adjuvant setting, Keynote 91 and Ampere 010. So we'll discuss briefly. This is the Aegean trial where durvalumab has been combined with platinum doublet, and it has been combined with platinum doublet with placebo. So in the Aegean study, they have asked the question whether does neoadjuvant durvalumab in addition to chemotherapy followed by adjuvant durva improve PCR and event-free survival, especially in stage 2, stage 3 non-small cell carcinoma, and you can see the PCR rate, pathological complete response almost 4 times, 4% to 17%, and major pathological response, that means less than 10% viable cells. So it has increased almost 3 times. Similarly, the Keynote 671 Pembro plus platinum doublet has been compared with platinum doublet, and it has shows improvement in event-free survival as well as overall survival. Also, pathological complete response PCR has improved, and the Checkmate 81C, similarly, nivolumab plus platinum doublet, PCR improved from 2 to 24%, MPR also improved from 8 to 36%, a improvement in EFS. So this is the Checkmate 770, similar nivo plus chemo followed by nivo maintenance here instead of only neoadjuvant, and there was improvement in event-free survival. So will these significant improvement in event-free survival will be translated to OS benefit? Because we have seen the Pacific data just presented by Dr. Srigopal. Few years back, we had similar situation, whether the EFS benefit or DFS benefit will be translated to OS, but 5 years down the line, and you can see the Pacific data. So let's be optimistic that the perioperative IO approach translate to an OS benefit in the future, so that we can confidently use those molecules. And the question arises, a neoadjuvant, adjuvant IO. So how do we decide? So Dr. Lipsita, which one you will prefer, neoadjuvant IO or adjuvant IO? Because there are a lot of advantages of neoadjuvant, especially neoadjuvant takes care of the micrometastasis and early treatment response. You can guide your treatment in adjuvant setting, and increased treatment initiation. Also, it improves patient compliance in comparison to adjuvant setting. So, which setting IO you will prefer?
Since lung, when it is we are planning for a resection and the disease is there, I think we should go ahead with neoadjuvant approach more than later on may be considered. I mean, adjuvant is considered in few, but I think neoadjuvant should give us a better result, because surgery is one thing that we want. I mean, a good resectable lung cancer will give a better survival. So I think I'll go with the neoadjuvant approach more than adjuvant.
Dr. Saurabh, you are there?
Yeah, Prashant bhai. So
yes,
please.
Nowadays, now IO has been added to chemotherapy in early stage non-small cell lung carcinoma also. So which one will prefer, neoadjuvant or adjuvant, and why?
So basically, my simple argument for neoadjuvant would be that the duration of therapy here is limited. So I'm not talking about perioperative therapy. I'm just saying a couple of cycles of therapy before surgery, and after that, see the results of the surgery, rather than adjuvant where you have to give it for a longer duration of time.
Yes. So that is an advantage of using neoadjuvant.
Please
And
go to mute, please.
After all, he's boy.
Organizers, you can mute the background noise.
Yes.
Yes, sir. Yes, sir. We are working on it.
Okay, so even most of the guidelines they have recommended neoadjuvant IO is preferred over adjuvant IO in combination with chemotherapy. So in this patient, stage 2 adenocarcinoma T2N1, T2N1, and it came out to be EGFR positive in molecular test. It is L858R positive. Dr. Lipsita, what adjuvant therapy will recommend? This adenocarcinoma T2N1.
As of now, NCCN guideline also says that in adjuvant therapy, if the patient is EGFR mutated, then we can go ahead with osimertinib 8 GOD.
Only osimertinib, or will you go chemotherapy along with osimertinib? Okay, so
I think we can answer this. So basically, chemotherapy has been shown to have additional benefit in EGFR mutated patients. So probably I'll go for EGFR before giving anti-EGFR therapy. I'll go for chemotherapy and then anti-EGFR therapy.
Yes. So chemotherapy, adjuvant chemotherapy should be given, but you can follow up it with adjuvant osimertinib based upon the ADURA data. And adjuvant role of benefit of adjuvant chemotherapy, we know several trials previously based upon which the adjuvant chemotherapy was the standard of care. This less meta-analysis shows almost 5.4% OS benefit, and these are the adjuvant chemotherapy regimen we have used in previous few years back. Those are the standard of care. The ADURA data promising. There was DFS benefit, significant improvement in osimertinib versus placebo. So previously, several other trials like erlotinib, gepitinib, they have failed. But in the ADURA trial, one thing we have noticed that most of recurrence are loco-regional. And we know that the loco-regional recurrence is associated with longer post-recurrence survival than distant recurrence. And because osimertinib has very good CNS penetration, so the CNS metastasis or relapse is less in the osimertinib or ADURA trial in comparison to other drugs. So these are the adjuvant therapies. As we have discussed, PD-L1 EGFR should be tested in early stage lung cancer. Alectinib in ALK positive setting, recently approved based upon ALINA trial, osimertinib and IO drugs, atezolizumab, pembrolizumab, durvalumab recently approved. And if you have used pembrolizumab in neoadjuvant setting, you can continue in the adjuvant setting. So these are the adjuvant drugs recommended, including alectinib, osimertinib, and IO drugs. And this is the adjuvant atezolizumab trial, IMPAR 010, where based upon which atezolizumab adjuvant atezolizumab has been recommended, especially in PD-L1 more than 1%. So, Dr. Lipsita, based upon this promising data, in your opinion, whether this ADURA data is practice changing? So this is my last slide. Dr. Saurabh. So though we have not yet reached the final or mature waste data, Dr. Saurabh. So based upon this ADURA trial data and significant improvement in DFS.
Yes, so Prashant bhai, I would say ADAURA brought about a lot of DFS benefit, but there are
Yes.
certain problems with the trial design, and
Yes.
therefore I would still feel that osimertinib adjuvant is not yet prime time in lung cancer. I would discuss it with
Will
the
you wait
patient.
the mature OS data?
Yes, yes, probably mature OS
Yes.
data. One of the biggest reasons why I'm saying is that
Yes.
majority of the patient did not get osimertinib at progression. Now that is something which
Yes.
is worrisome, right?
Okay. Thank you. So I'll conclude here, and we can take questions later on, Dr. Saurabh.
Yes, yes, yes,
Okay.
yes, exactly.
Okay. Thank
So
you.
thank you, Dr. Prashant, for taking us through the entire spectrum, diagnosis of lung cancer, staging of lung cancer, what are the biomarkers you need to do, what are the neoadjuvant approaches, adjuvant approaches. So really interesting. Thank you there for this presentation. So now we will go to the next presentation, and that would be by me. So Prashant bhai, can you stop sharing your screen? Yes, now I will share my screen. So is my screen visible? Is my screen visible?
Yes.
Yes,
Yeah,
sir.
yeah, fine, fine. So basically, today's discussion was on the recent advances in the management of mostly EGFR mutated lung cancer sponsored by AstraZeneca. So I will be presenting 2 or 3 real world case scenarios. So patient with resected lung cancer, we have all discussed this in by the previous speakers. I'll just try to put some perspective into it. So patient with a resected lung cancer has a EGFR sensitizing mutations. Is a 55-year-old female, stage 2B adenocarcinoma, EGFR exon 19 deletion. Now I'll discuss about adjuvant or osimertinib pros and cons. So basically, this was a very important data, ADAURA, starting with the DFS, finally coming to the OS in a matter of 3 years. Now, this was the study which was presented. That is osimertinib as an adjuvant therapy. This trial has already been discussed. This graph has already been shown. So very clearly, there was a disease-free survival benefit. Subsequently, when we saw that there is an overall survival benefit also, when that means patient live longer when you give them osimertinib as compared to no osimertinib. So that is what was the final outcome of this study, plenary session presentation. But there are certain cons in this. So one most important thing, we know that osimertinib is the standard of care in patients with metastatic or advanced stage lung cancer with EGFR mutation. But in the ADAURA trial, 1 in 3 patients in the placebo arm, they never got osimertinib at progression. So FLORA was the study which showed that osimertinib as a frontline treatment option in advanced lung cancer improves survival. So in one arm, we have osimertinib, which is given. In the other arm, the treatment at progression, many of the patients did not get osimertinib post progression. Now that is something worrisome, as you can see in the LAURA trial, that is in which they gave osimertinib after concurrent chemoradiation. You see almost at progression, 80% of the patients crossed over to the osimertinib arm. Now that is what is a trial scenario. Now here this did not happen. So I have to see that in the placebo arm, the optimal treatment probably was not got by many treatment patients at progression. Now that puts a question to the outcome of this study. So of course, one arm was bit inferior compared to other. Now baseline MRI and PET-CT was not mandatory. As we discussed before also, even in early stage 2 disease, that is stage 2, there are chances of occult metastasis. It could be 6%. When you don't do baseline MRI or PET-CT scan, your chances of missing out on this occult metastasis is there. So probably you are not treating truly adjuvant setting, but you are treating some of the stage 4 setting where already osimertinib is known to be better, right? So MRI and PET-CT was not mandatory. Adjuvant chemotherapy was not received by all. Now this should have been again the standard. So basically in those patients whom you are having chemotherapy, as we saw, there is 5% overall survival benefit without chemotherapy in patients. So giving all patients, so many of the patients have not received appropriate chemotherapy, right? That also brings to question the results. Primary endpoint was disease-free survival. So we are looking at the secondary endpoint of OS, although which showed improvement, but the primary endpoint was DFS, so statistical analysis. DFS as a surrogate for overall survival is not ideal for drugs such as TKIs or IOs. Mostly it would probably be for cytotoxic drugs, but for TKIs and IOs, TKIs which are cytostatic, this could be brought to question. Finally, cost effectiveness. Now, although cost is not always discussed in the setting of academic discussions, when we are going to give a long duration of therapy, we should be very careful that what we are giving. Having said that, this patient with the resected lung cancer, after discussing with the pros and cons, he was offered adjuvant osimertinib, but he chose to continue only with chemotherapy with financial constraints, right? So that is about the summary of the adjuvant EGFR. Now we come to the stage 3 locally advanced adenocarcinoma lungs. EGFR mutation is present. He has been treated with concurrent chemoradiotherapy. How are you going to consolidate this patient? So again, here we will discuss post-chemoradiotherapy. What are the pros and cons of the LAURA trial, that is adjuvant osimertinib in this setting? So this was already very well discussed. In the stage 3, chemoradiation is the standard of care, concurrent chemoradiation. And concurrent chemoradiation is better than sequential chemoradiation. So if you give chemo along with radiotherapy, best survival compared to chemo followed by radiotherapy or vice versa. So concurrent is the standard of care. And after that, we go for durvalumab because this strategy has been shown to improve the overall survival of the patient, those who have received concurrent chemoradiotherapy. This was the PACIFIC study. However, even if the patients with concurrent chemoradiation had improvement in survival with durvalumab, with EGFR mutation, this would not be seen. So durvalumab probably is or not performing as a maintenance strategy. And with this understanding, actually the LAURA trial, which was presented, got a standing ovation also. See what is real world scenario like that also. In this scenario, we have all patients, they have received either a concurrent chemoradiation or a sequential chemoradiation. So many of our patients would not be able to get a concurrent chemoradiation, but the LAURA trial did include also those patients who received a sequential chemoradiation. Then it randomized them to after chemoradiation to osimertinib versus placebo. Very beautiful separation of the curves. This is the CNS progression free. So brain also, patients had a very good control in the brain. So patients had a very limited recurrence in the brain. And also this study led to significant disease progression-free survival across all subgroup of patients. And as I said, 80% of the patients crossed over. Now that is important. Now that means at progression, these patients were given osimertinib, which is very important because that way it balances both the arms. And therefore, probably we are not seeing an overall survival benefit in future. It may be there because the data is still not mature. We only have 20% events. 80% events are still left behind. And the toxicity wise, when you give osimertinib, there would be some interstitial pneumonitis which can be managed. So the cons in this, again, PET-CT and MRI brain imaging was not mandatory even in this subset of patients. So possibility of missing out on occult disease. OS data is overall survival is still immature. Toxicity is there. Cost is also to be considered. However, in the recent ESMO, they presented this data. Those who had undergone PET-CT scan versus no PET-CT scan, they clearly showed that the survival in progression-free survival benefit was still maintained, showing that even if the patient was staged without a PET-CT scan, the outcomes are similar. So in our patient, based on this very robust data, showing very significant improvement in progression-free survival, after chemoradiation, this patient was put on adjuvant osimertinib and is currently doing well. Finally, we come to the last scenario. We discussed this sometimes back, resectable adenocarcinoma of the lungs. Dr. Prashant discussed we have to go for immunotherapy plus chemotherapy, that is the neoadjuvant. Now, what about those patients who have EGFR mutation? Now we have data in metastatic with EGFR mutation, osimertinib, You now have with maintenance EGFR, that is the consolidation adjuvant osimertinib after concurrent chemoradiation, we have adjuvant osimertinib after resection. Is there a neoadjuvant osimertinib? What is the data for that? There was one study for this, a phase 2 study, and this was a negative study. The pathological response rate or the major pathological response rate with osimertinib was only 15%, which did not meet the primary endpoint of the study, and therefore probably neoadjuvant osimertinib did not result in, in the expected outcome as we would have thought of in patients, and therefore this is not a standard approach. So I would conclude that adjuvant osimertinib based on ADAURA improves DFS. OS is also increased in resected adenocarcinoma with the caveat that there have less of crossovers. We have to discuss this approach to the patient rather than to give all the patients with adjuvant osimertinib. LAURA data is, however, a very, very significant data, I would say. Adjuvant, although the OS is still immature, still at least osimertinib improves the progression-free survival in unresectable adenocarcinoma with EGFR mutation treated with concurrent chemoradiotherapy and could be the standard of care in our patients. So that is all from me. Finally, we will be going to the last presentation. I'll stop sharing now. So the last talk is on there was a debate actually. So unfortunately the speakers are not there. So I would request the participants who are there to give their opinions on this, and then we can take. So basically, I would like to take opinion for Dr. Prashant Parida. So Prashant bhai, basically in those patients who are having brain metastasis, and if there is a sensitizing EGFR mutation, let us say, now would you go for, what is your perspective, whether we should go for local radiotherapy or we should just go for EGFR TKIs?
So, Dr. Saurabh, because as we have already treated a lot of patients with CNS, if someone is asymptomatic. So, because osimertinib has very good CNS penetration, and I can start with only EGFR TKI like osimertinib. But if someone is symptomatic, multiple CNS metastasis or focal deficity, like things will be there, then radiotherapy has a role.
Fine. Dr. Lipsita, what's your take on this? Metastasis to the brain and EGFR sensitizing mutation, osimertinib versus osimertinib plus local therapy. Sri Gopal, Dr. Sri Gopal, are you there? Dr. Sachin, fine. So basically what Dr. Prashant has said, I would also echo the same thing. The patients who are having a sensitizing mutation in the brain, now we have drug osimertinib, which is a very good CNS penetration. Now, if this patient is grossly asymptomatic, then I would probably go for only TKI, that is the osimertinib, and continue the therapy. We have seen really good responses with the osimertinib in this setting, and probably if the patient has a progression or if becomes symptomatic at that point of time, I would like to add a local therapy in the form of radiotherapy. But being that, having said that, we have also Dr. Sthiti Das, she is a radiation oncologist. So we can hear her perspective. Madam, are you there?
Dr. Saurabh, probably she has left. Okay.
No, I'm there. I'm there.
Okay, so madam, basically, suppose as I say in the same scenario, suppose a patient has brain metastasis and also EGFR mutation. So when do you go for radiotherapy or we just go for osimertinib?
Yeah, being a radiation oncologist, I will just beg to differ from you all because what we have seen is even though there is a brain metastasis and asymptomatic, like it is very difficult to closely follow up or observe the patient. But if you see, we can offer stereotactic radiosurgery for such patients because one, it helps us increase the local control. And if you see the like analysis, prospective and retrospective analysis also, you can see that these patients, there is like very less time to CNS progression and a good local CNS control is also there. And if you also see, there are some papers by Song et al. And some studies where we have seen that the radionecrosis was very less if we have like offered upfront SRS to these patients. Some papers we have seen, some studies we have seen overall survival was also better with if TKIs, SRS was added to TKIs than only TKIs. So according to me, if we see these patients, like we can chip in for these patients where we can add to the local control and we can also add to the progression-free survival for these patients, as well as we can also preserve the neurocognition for these patients because owing to better response with TKIs and longer overall survival, we know these patients will live a long life, at least 2 to 3 years we're expecting this overall survival. So at least we can vouch on this neurocognitive impact, which stereotactic radiosurgery offers in comparison to whole brain RT. And let me tell you, even if there are multiple lesions, like single lesions, more than 1 centimeter lesions, we definitely are going to offer SRS for these patients. But even if the cumulative volume is like lesser than 15 cubic centimeter, even if at in more than 5 lesions, up to 10 lesions, we can offer stereotactic radiosurgery for these patients. So I will actually support the fact that stereotactic radiosurgery will actually help us get better control over these lesions.
So you mean to say even if it is an asymptomatic metastasis, you'd still go for stereotactic radiosurgery? That's what you mean to say?
Yeah, because sometimes we have seen that even more than 1 centimeter lesions, they may not be symptomatic, but they may again become symptomatic. So I don't see practically we can actually follow these patients. So it is better to radiate these lesions and add to the survival of these patients.
Right. I think what is very important here is the follow-up. Now, if you are able to do a periodic MRI, let us say 2 months, 3 months, very particular patient, and he is very compliant, then it is probably it is worth the discussion that yes, we would like to keep your asymptomatic lesion, but in India, it's practically very difficult. So at the onset, when we are diagnosing with the patient, we can go for this drug. And of course, osimertinib is a very important drug. It has a good leptomeningeal activity also. 50% is the response rate, and the overall response rate and disease control rate is 80%. And also brain metastasis is a very good activity. So many patients, those who are symptomatic, at least we can combine osimertinib along with stereotactic radiosurgery, and then we can get a decent outcome. So I think that would be all from us here. It was great learning for all of us on EGFR mutated lung cancer, bearing a few technical glitches for which we are really sorry. I would say that still we have 80 participants as of now. And I would really like to thank all the panelists, all the speakers, those who have contributed to this discussion. I would like to thank International Association of Integrated Oncology for technical help. And I would like to acknowledge AstraZeneca for their academic grants for conducting this event. So thank you, everyone.